we will discuss osteoarthritis and rheumatoid arthritis as comparison to appreciate the similarities and differences between the two conditions. So if we compare a joint that has osteoarthritis with the normal joint, we will find that there is loss of the joint space because the articular cartilage has degenerated. So this is where osteoarthritis starts, degeneration of the articular cartilage leading to loss of the joint space. And of course, the result of that will be a lot of friction between the articulating surfaces of the bones involved in the joint, and this creates pain, especially with activity. Whereas in rheumatoid arthritis, early on, we can notice that the articular cartilage is intact. But what is inflamed and thickened is the synovial membrane. Because rheumatoid arthritis starts in the synovial joint with significant inflammation. Later on, the inflammation will spread into all structures inside and outside the joint, leading to a lot of destruction and deformities of the joint. So osteoarthritis is mainly a degenerative condition, whereas rheumatoid arthritis is inflammatory. Osteoarthritis is more common than rheumatoid. It's like 10% of the population. And it's a disease of aging because it's degeneration. So usually begins later in life after the age of 50 or 60, whereas rheumatoid arthritis being an autoimmune disease, it tends to happen in young adults, especially females. And by the way, women are also more frequently and severely affected with osteoarthritis. Osteoarthritis is minimally inflammatory. Actually, this is a better term than non-inflammatory. Minimally inflammatory disease of the joint that is characterized by degeneration of the articular cartilage, whereas rheumatoid arthritis is an inflammatory autoimmune condition, and when it affects the joint, it starts in the synovial membrane, and the synovial membrane becomes a thick layer of granulation tissue known as pannus. So osteoarthritis is degenerative, it's an aging phenomenon, but some factors can accelerate this degeneration, like obesity, because obesity is some sort of like trauma to the joint. That's why we notice that osteoarthritis is more in the weight-bearing joints. Also, joint injury. Therefore, football players, soccer players, basketball players, if they sustain joint injury in their 20s, like ankle injury, this particular ankle where they had previous injury will develop osteoarthritis pretty early. Maybe in their 40s, they can have significant osteoarthritis in that joint. Why? Because that was the joint that had joint injury many years before. Also, overuse of joints can accelerate the process of degeneration of the articular cartilage, and hereditary might play a role as well. Whereas rheumatoid arthritis, because it's an autoimmune condition, we do not actually know why it happens and what accelerates or what increases its incidence. It starts as inflammation of the synovial membrane. Later, the inflammatory process extends to destroy the articular cartilage, the joint capsule, the tendons, and the ligaments around the joint as well. Osteoarthritis can affect any joint in the body, but primarily it affects the weight-bearing joints. And the most important weight-bearing joint in the body is the knee. So the knee, the hip, and the spine. These are the joints that are affected by osteoarthritis. Also, the joints of the hand can be affected by osteoarthritis. And here, the precipitating cause is, or the predisposing cause is overuse. And when osteoarthritis affects the hand, it does not spare any joint. It can even cause even the distal interphalangeal joint, the very distal joint in the fingers, can be involved in osteoarthritis. So this joint, the DIP or the distal interphalangeal joint, is usually spared in rheumatoid arthritis. And this is an important point of comparison between osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis spares the distal interphalangeal joint, but osteoarthritis can affect it. And usually the joint involvement in osteoarthritis is asymmetric. So when it involves the knees, there will always be one knee that has more advanced condition than the other. Maybe this is related to the way you walk, how much weight you place on each knee. Maybe this is related to an old trauma. It's never symmetric. It's never symmetric. On the other hand, rheumatoid arthritis, still, again, it can involve any joint in the body. But when it involves the hand, it prefers to involve the metacarpopharyngeal joint, this one, and the proximal interphalangeal joint, the proximal finger joint, PIP and MCP. And it usually spares the distal interphalangeal joint. Rheumatoid arthritis can involve any joint in the body. And usually the joints involved in rheumatoid arthritis are symmetric. So the joint involvement is symmetric. This is an important contrast point between rheumatoid arthritis and osteoarthritis. Osteoarthritis most of the time is asymmetric. Rheumatoid is symmetric. Osteoarthritis is only a disease of joints, because where else do we have articular cartilage? But rheumatoid arthritis is a systemic disease because it's an autoimmune disease, and it begins with general systemic manifestations of inflammation, maybe low-grade fever, fatigue, weakness, anorexia, weight loss, generalized aching, followed by involvement of joints, and joints become painful and swollen. And rheumatoid arthritis is kind of chronic arthritis, and it can be interrupted. It can start by acute manifestations, but most of the time it's some sort of insidious, gradually developing chronic rheumatoid arthritis with some flare-up attacks or flare-up episodes. And also, in addition to the involvement of joints, we can have rheumatoid nodules extending extrasynovially into the skin, heart valves, pericardium, pleura, lung, and even the spleen. If we come to the clinical picture, in both conditions, there are joint pain and joint stiffness. In osteoarthritis, the pain is worse with activity and better with rest. That's why patients with osteoarthritis, when they wake up early morning, they feel okay. But as they exercise and walk and sit and climb stairs, all this creates more friction between the bones without articular cartilage covering them. So at the end of the day, they feel the pain. Osteoarthritis patients wake up every morning with a very brief period of morning stiffness. The joints feel stiff, but this usually lasts for 5 to 10 minutes max. It's not even 30, 5 to 10 minutes max. And after that, the joints are okay. Whereas the very, very, very characteristic symptom of rheumatoid arthritis is prolonged period of morning stiffness, literally not less than 1 hour. Not less than 1 hour. And here's the explanation of this. We know that cortisol is a very potent anti-inflammatory hormone. And cortisol level ceases in the evening and is almost not there in overnight. So your adrenal cortex starts producing producing cortisol very early morning, like 5 a.m., 6 a.m., which means all overnight, you don't have enough cortisol. You don't have enough anti-inflammatory hormone. So the inflammatory process goes on and on all overnight with accumulation of inflammatory mediators and chemicals. And this will cause significant symptoms, which is the prolonged period of morning stiffness. Then, with the early production of cortisol, this morning stiffness will take time to resolve. And actually, the pain of rheumatoid arthritis gets better with activity, probably because activity allows or helps draining the inflammatory mediators outside the synovial cavity of joints. And during the acute attack of rheumatoid arthritis, the joints show the manifestations of acute inflammation, red hot, tender, swollen. During chronic attacks, the joints are just painful and might be a little bit tender. Deformities. In osteoarthritis, because of the friction, you get new bone formation in the form of bony nodules or nodes. When these nodes develop in relation to the proximal interphalangeal joint, we call them butchered nodes, and nodes developing at the distal interphalangeal joints are called Heberden nodes. So these nodes occur in osteoarthritis. In rheumatoid arthritis, when it affects the hands, you get ulnar deviation of the hand, and you get swan neck deformity, which is extension of the proximal interphalangeal joint with flexion, compensatory flexion of the distal interphalangeal joint. That's the swan neck deformity. And also we get the buttonier's deformity, or the buttonhole deformity, that looks like this. So these are the deformities in rheumatoid arthritis. If we looked at an X-ray of osteoarthritis, the first thing you can detect is loss of the joint space. See, the joint space here is absent. Even in the same joint, see how asymmetric it is? The joint space here is okay, it's intact. And on the medial half, or the medial aspect of the joint space is lost. That's one thing. And you get sclerosis of the articulating bones because of the excessive friction between them. And you get new bone formation, again induced by the friction, called osteophytes. All these are findings of osteoarthritis in an X-ray. In this advanced case of rheumatoid arthritis, first you can notice the ulnar deviation in both hands. And of course, you notice that the condition is symmetric here, the involvement is symmetric. And you can see here some destruction. See the bones of the wrist destroyed by the inflammatory process. But interestingly, the distal interphalangeal joint does not show any evidence of destruction, because rheumatoid arthritis does not go there. Look at the metacarpophalangeal joints, obviously deformed, very obviously deformed. These knuckles, rheumatoid arthritis prefers these metacarpophalangeal joints. There is no actual blood test to diagnose osteoarthritis, so no blood test. In rheumatoid arthritis, we have many blood tests. We have the famous rheumatoid factor, and now anti-CCP is considered the most accurate test to diagnose rheumatoid arthritis, even much better than detecting the rheumatoid factor. Because osteoarthritis has minimal inflammation, so the treatment is just analgesics, simple analgesics like acetaminophen. Whereas rheumatoid arthritis, acetaminophen does not work because acetaminophen has no anti-inflammatory effects. So we need something like NSAIDs for the symptoms, but we need potent immune modulators because it's an autoimmune condition. So we use what's known as the DMARDs, the disease-modifying anti-rheumatoid arthritis, like methotrexate. So if we look at a normal hand X-ray, normal and intact joint space, and all joints look normal. Look here in osteoarthritis, we have involvement of the DIP, involvement of the PIP, and we can have nodules in relation like Heberden for the DIP and Butchert for the PIP. Normal knee X-ray with an intact joint space, or through here, we have lost joint space due to the degenerated articular cartilage. Same with the hip X-ray. One single criteria is not enough to diagnose rheumatoid arthritis. You need to have at least 4 of the following to diagnose rheumatoid arthritis. Morning stiffness of the affected joint lasting for more than 1 hour for 6 continuous weeks. Swelling of 3 or more joints, so it's a multi-articular disease. Involvement of the hand joints for more than 6 weeks. Symmetric joint swelling. Subcutaneous nodules might be present. Positive rheumatoid factor and an anti-CCP. And deformities noted on radiography. You need to have combination of these in order to diagnose rheumatoid arthritis. If we look at this mini case study, a 34-year-old woman with pains in both hands for a few months and stiffness, prolonged morning stiffness. It improves as the day goes on. Multiple joints swollen. X-ray hands show some erosions. What is the single most accurate test? It is not the rheumatoid factor, but it is the anti-cyclic citrullinated peptide, the anti-CCP. This is the and why is it better than the rheumatoid factor? Because rheumatoid factor is only present in 80% of patients, and it is not specific and could be present in other diseases. For example, Hashimoto thyroiditis. It's an autoimmune disease, and rheumatoid factor can be positive in Hashimoto thyroiditis. But the anti-CCP is the single most accurate test for rheumatoid arthritis. It's more than 95% specific for RA, and it appears earlier than rheumatoid factor in the course of the disease. More pictures of the ulnar deviation of hands in rheumatoid arthritis, Bottier-Nerz and swan neck deformities. When rheumatoid arthritis involves the knee, a cyst can develop, inflamed cyst can develop at the back of the knee at the popliteal fossa, and we call it Baker's cyst. So this table illustrates some point of comparison between OA and RA. The most significant symptom in RA is the prolonged morning stiffness, and the most characteristic symptom in OA is the involvement of the distal interphalangeal joint, which is usually spared in rheumatoid arthritis. Of course, when you take sample of the joint fluid, it has minimal number of leukocytes in OA, and it has significant high number of leukocytes in rheumatoid arthritis. And this concludes the discussion of arthritis and joint disorders.